Hi, I'm Giordano Botta, the CEO and co-founder of Allelica.
I'm Dr. Elizabeth Epstein. I'm a preventive cardiologist with Scripps Clinic Medical Group. I work at the Scripps Center for Integrative Medicine in San Diego.
Dr. Epstein, it's wonderful to be here with you today. Could you start by sharing a little bit about your background and your personal approach to patient care?
Yeah, so my passion is in prevention and reversal of coronary artery disease, so preventing heart attacks and strokes and preventing suffering. And I have a background in general cardiology, training in general cardiology, but also integrative medicine. So I did a fellowship in integrative medicine where I have expertise in lifestyle modification and using all available modalities to prevent and reverse disease, and background in lipidology. So putting all that together to understand patients' risk of heart disease and prevent suffering down the road.
We know that it's still pretty common practice among cardiologists to rely only on traditional risk factors such as lipid panels, blood pressure and age, and also to calculate the 10-year risk with the pull cohort equation. Did you encounter any recurrent limitations with using these traditional approaches?
Absolutely. So the key to prevention is doing a thorough risk assessment to start. And using equations like the PREVENT calculator or the pooled cohort equation are definitely a place to start. But in order to move towards personalized precision medicine, we have to be more elegant. And we know that cardiovascular risk prediction is really a multifactorial equation. So I often, I like to start with the PREVENT equation, but it doesn't incorporate all of the risk factors that contribute to risk of cardiovascular disease. So the more we can be elegant and refine that calculation, look at risk modifiers, both from the patient's history, different lab markers, and polygenic risk scoring, we can be more elegant, refine our risk calculation up or downgrade risk based on additional factors.
So at Allelica, we have seen how fast PRS has been adopted in clinical practice in the US, but also internationally. But we still consider providers like to be innovators, those that want to go the extra mile to really understand new technologies, to really provide the best care for their patients. So I was curious to know, how did you first learn about polygenic risk score and what made you decide to start using it in your practice?
It is still part of the cutting edge of prevention, and that's where I really want to be and be able to offer that for my patients. And at the same time, we have almost a decade's worth of data accumulating in cardiovascular disease space showing the power of PRS for cardiovascular risk prediction, especially in young people in their 30s, 40s, but throughout the lifespan. And so I really, go where the data goes. We have some fantastic studies published in excellent journals that support the use of PRS as an independent predictor of cardiovascular events. And even now, data showing predictor of soft, vulnerable plaque in the coronary arteries. So I have to pay attention to that and consider that to be a powerful risk modifier, just like imaging of the coronaries would be.
If you can describe a case where PRS provides insights beyond traditional risk factors, and how do you use these insights in your care?
Yeah, I had a really great case recently, a 41-year-old gentleman, really healthy marathon runner. And I think the type of patient who wouldn't normally be considered high risk for coronary disease at all. Might have been a sort of forgotten patient in the past. Had some elevated LDL cholesterol that started to raise red flags to the primary care doctors, and the patient was also very engaged in advocating for himself as well. So LDL in the 130s, 140s, elevated Lp(a). But the PREVENT calculator still calculated out low 10-year risk, a lot probably to do with his age, how young he is, and intermediate 30-year risk. We did a PRS on him and found that he was in the high risk category for coronary disease, also high predilection for hyperlipidemia and elevated Lp(a). And so I upgraded his risk from low 10-year risk to intermediate 10-year risk, and his 30-year risk I would consider to be high. And that helped determine our treatment. So he could not tolerate even a baby dose of a statin because he's a super marathoner, so it did cause some muscle aches for him. And it influenced me to choose PCSK9 inhibitor for him because we really wanted to achieve a larger drop in his cholesterol to protect him in the long term. And so I think we wouldn't have understood his risk had we not obtained the PRS score.
One thing that is very important to remember is that PRS does not replace existing risk factors, existing tests, but complement it, especially because it identifies individuals who are not detected at high risk by traditional risk factors. So those individuals that are flying under the radar. And so how do you see PRS complementing existing tests?
It's a powerful risk enhancer, and exactly like you said, it's one piece of a bigger equation. We're still understanding all those pieces, but the patient's history, the patient's family history, the patient's polygenic risk scoring, their labs, their, including cholesterol, inflammation, other risk enhancers. The more we can draw in, plaque assessment in the body, coronary imaging, carotid ultrasound, femoral ultrasound imaging. So the more pieces we bring in, the more we can refine that risk equation and get an even more elegant assessment of that patient's risk. And that's what I call 360-degree risk assessment. So it's one piece of the puzzle, one important piece of the puzzle, absolutely.
What you consider to be the most important value added of polygenic risk scoring is this 360 risk assessment. It's something that can really provide more confidence in your approach to care.
Yeah, I think, the data has shown that it is actually a really powerful predictor. Those in the very high risk category can have up to, 3-4 times the risk. So that is something that we absolutely can't ignore. That's putting someone, and the studies have shown can put someone up in the range of someone with FH that we're very comfortable considering automatically high-risk patient who needs aggressive treatment. So it helps identify additional patients that are in that category on that side of the spectrum. And then it can also help reassure us if we're getting a low-risk calculation and the PRS comes out low, we feel even more certain that patient may not benefit from treatment of cholesterol. That would be a patient who focusing on lifestyle modification is the appropriate treatment. So it really, again, it just helps refine our treatment on both ends of the spectrum. On the bulletproof end of the spectrum, where they've gotten good set of genes are not going to build plaque in the body, versus those who are on the very high risk end of the spectrum. We're not going to miss those who are building plaque early in life and who are at risk of an early heart attack.
One area that we see growing interest is also cascade screening, so using a patient results to inform testing for family members. Do you see any value of using PRS for cascade screening? Can it provide clarity among family members?
Absolutely. I think, we're moving more towards, upstream prevention of disease. So if someone in their 50s is having a risk assessment done, and this is something that can inform, young adult children or even children that they're at an increased risk, they can be seen for a thorough risk assessment early in life, understand their risk throughout the lifetime and what to be aware of as they age. So, and we know that even small changes early in life can have dramatic effects later on. So the more you maintain it, it's not only the magnitude of treatment, but it's the duration of treatment. And so the more we can intervene earlier for family members is extremely powerful. So I do think it has a role in helping protect not only the patient, but also their family.
We've spoken with a lot of cardiologists that they are highly interested and they also understand the value of polygenic risk score, but they can be a little bit concerned about how polygenic risk score can fit in what is already a very busy routine clinical schedule. So how have you integrated PRS in your existing clinical care? Was it compatible?
The concern is that it's going to take a lot of time to do this type of counseling, and what am I going to do with this information? So I found that setting the patient up for what is to come when we just make the decision to order the PRS is really key. So I kind of ask the patient, are you someone who wants to be empowered with information? Do you want, you're going to take this information, we're going to make changes, we're going to understand that genes are not destiny, this is not a crystal ball. Or are you someone who's going to be extremely stressed and anxious by this information, and maybe this isn't for you? We don't have to do this. This is a way that we can refine our risk calculation for you. So I kind of set them up, make sure that they're the right person to order the test. And then I let them know that it's going to be an in-clinic visit where we're going to go over the results and we're going to assess how this impacts your risk calculation and make a decision based on that in terms of your treatment. So I always say it's going to be in person where we're going to go through it. It's more of an in-depth discussion about the PRS and set them up that it's not going to be something happening in the clinic inbox or over the phone. It's going to be something that we talk about face to face and incorporate and make a decision how to move forward together. So I think setting it up and recognizing it is going to take some time. Maybe it's going to be a clinic visit, one whole clinic visit where you're following up on the results and making the treatment decision together.
Okay, and was the process easy to implement, or did you find any main difficulties really make this a reality in your clinic?
Yeah, I found, especially if I chose the right patient who was interested in that process, and I found it very easy to implement and incorporate into our 360-degree risk assessment we were already working on.
Is this something you introduce early in the prevention journey or after some additional testing?
Yeah, I usually start with an assessment of cardiovascular risk with the patient where we're incorporating multiple different modalities into that risk assessment, and I offer polygenic risk scoring as, a cutting edge test that we can add to refine that risk equation. And so then we can move forward from there. We'll usually do our initial risk assessment. We can start some treatment based on that and say, well, we're going to actually refine it. We're going to get more information. And then next time we can say, do we need to intensify therapy, or are we going to stay with our initial assessment with the prevent equation, for example?
So how do you go about selecting the patients that can benefit the most from this testing?
So we know from the data that any age group can benefit. There's a predictive value of PRS at any age, but it's even more powerful in younger patients in the 30s to 40s range. And so definitely those patients are people who I like to think about PRS, especially thinking about PRS over something like a calcium score, because that's the same group in whom a calcium score isn't as predictive. And so I may lean more, if I want to refine the risk assessment, lean more towards PRS and away from calcium score, because even calcium score of 0 in those patients may not tell us so much, as they may be too young to have built plaque in the body and calcify plaque in the body.
Yeah, especially because a few years ago there was like this concept of the power of 0, but now the latest data they really show that it's not really the power of 0, because there are patients that can have these soft plaques that are not identified. So do you think that PRS also can be a useful tool to identify who should be assessed for the soft plaques as well?
Absolutely, and I think there's brand new data coming out to show that there's an association of PRS with soft plaque in the coronary arteries. So we actually have data to show that there's an association with plaque. There's an association with outcomes. So that's really what we love to see with a risk assessment modality.
So we know how important it is to engage patients in the preventive journey to preventing cardiovascular disease, especially now that we know the power of this shared decision-making process. So I was curious to know, how do your patients usually respond when you introduce PRS testing? What's their first reaction?
So having a preventive cardiology practice, I end up having kind of a self-selecting group of patients. A lot of them are very engaged. They're the type of people who want to leave no stone unturned, and a lot of them really would like to incorporate all available modalities to refine that risk equation as much as possible. So I find I have quite a few patients who are really wanting to incorporate that piece of the puzzle. And so I'm really glad to be able to offer them, I think, the part of the cutting edge of prevention in cardiology.
How do patients generally react when they receive high risk result? So are they anxious, motivated, and how do you communicate with them?
I like to emphasize we don't go looking for bad news to give bad news. We go looking for information to be empowered. And that's something that I'm sure to emphasize prior to obtaining the test. And I emphasize genes are not destiny. We know from the data that this is something we can modify. So we're going looking for information that we can act on, and I want them to be empowered to make changes that will impact their risk. And I always tell them we're ahead of the ball. We're still ahead of the ball, nothing bad's happened. We can actually prevent suffering years down the road. So I think setting them up that way a lot of times works really well, and that they're empowered. They feel that they have the information. They're actually relieved to have a full understanding of their risk. And occasionally, I do have to have that conversation again and say, this is not meant to be anxiety provoking. This is, let's keep in perspective that this is meant to be empowering. So sometimes anxiety comes up with getting it, and we just have to go back to the fact that this is not destiny, this is empowerment.
It's really a risk factor that you can act upon, so you can really change the trajectory if you know this information.
Yes.
Now, what made you decide to use Allelica polygenic risk score compared to other options that are in the market?
I think the comprehensive panel that's available, so even not just coronary disease, but all the chronic diseases, and including the key, a lot of key risk factors for coronary disease as well: hypertension, hyperlipidemia, obesity, atrial fibrillation is on there. So it's really a fantastic panel. And then the chronic diseases of aging, Alzheimer's and cancer, which share common risk pathways through inflammation in the body. And so I'm open-minded to getting that entire panel for my patients and counseling based on that. So I really like the comprehensive nature of the panel. I like that it has been calibrated in different backgrounds and cultures. That's been a criticism of PRS, that it's most powerful in European ancestry, but I want to be able to offer it to all of my patients. And so I think that's a really key aspect of Allelica that's unique as well.
Absolutely, thank you. Yeah, so we have done a lot of work to be sure that our scores really work in people of any background, of any ancestries. So this is what we consider to be really something so important, that many of the risk models that we use now in the clinics, they did not have this kind of level and rigor of assessment and calibration.
Exactly. Some of our even more basic risk assessments may not be calibrated appropriately in different ancestries. So I think that's very key, and it's exciting that that was a focus for Allelica and allows us to be more confident offering it to all backgrounds.
If you have to look ahead, maybe in the next 5 or 10 years, how do you see PRS being used in clinical routine practice?
I think it's the cutting edge of prevention. I think it allows us to have personalized precision medicine. We're hearing in the news, we always hear about coronary disease. It's the #1 cause of death. We hear colon cancer is on the rise in young people. It's on the front page of the news. And people don't need to know what to do with that information. Do I live in fear? How does that apply to me? Does everyone need a colonoscopy every year? Does everyone need a CT scan of their heart arteries every year? And so understanding the role of your genes and gives you a place to start, and I think gives us the pre-test probability for additional risk assessment for each patient, and is going to refine how we do screening for all chronic diseases, coronary disease, but also cancer and also Alzheimer's. And I think this is really the key for how we manage chronic diseases of aging.
So thank you, Dr. Epstein. So this was really great and very informative. Thank you.
My pleasure. So great talking to you.